Hi, this is Dr. Poole, and this presentation will cover crystal-induced arthritis and some of the other common arthritides that will be discussed as part of this case. Crystal-induced arthritis includes gout, which is the deposition of urate crystals in joints and other tissues, and pseudogout, more specifically called calcium pyrophosphate crystal deposition disease. Gout classically progresses through three clinical stages called gout flares, intercritical gout, and chronic gouty arthritis and tophaceous gout. The clinical stages of gout can be regarded as emerging sequentially, but with some overlap, with clinical severity that often parallels the frequency of gout flares and leads to the eventual development of chronic gouty arthropathy and tophaceous gout. Upon resolution of a gout flare, the patient is said to have entered into an intercritical, that is, between flares period. Even after severe gout flares, the intercritical periods early in the course of gout are most often entirely asymptomatic. This progressive sequence is so uncommon in other arthritic disorders that its presence is highly suggestive of gout. A gout flare is typically monoarticular and intensely inflammatory, occurring in the lower extremities, especially the base of the great toe, at the first metatarsal phalangeal joint, or the knee. Signs of inflammation can also extend beyond the confines of the joint that is primarily involved. Tophaceous gout is characterized by collections of solid urate crystals accompanied by an intense chronic inflammatory reaction and often destructive changes in the surrounding connective tissue. The thickened, inflamed synovium forms a pannus that destroys the underlying cartilage. Tophi form in ligaments, tendons, and bursae, as well as on the ears, and these are pathognomonic for gout. Tophi actually are typically not painful or tender. They can cause disfigurement and may occasionally even ulcerate through the skin. There are two major renal complications of chronic hyperuricemia, nephrolithiasis, as well as chronic urate nephropathy. We won't discuss the details of renal complications further, but we'll pick that up again when we discuss kidney diseases later on. This slide graphically summarizes some of the different forms of gout, the clinical appearances and radiographic appearance, as well as the appearance of the crystals when seen in synovial fluid examination. I'll come back to that in a little while. Classically, gout flares occur at the first metatarsal phalangeal joint, as shown here, and are characterized by the classic signs of inflammation, pain, swelling, and erythema or redness of the involved joint. In chronic tophaceous gout, there is deposition of urates into a chalky mass known as a tophus. Tophi can appear around a joint and the adjacent bone, as shown here, and are seen radiographically as a hazy cloud. The tophi can eventually erode and destroy the adjacent bone. This slide illustrates the classic sites of deposition of tophaceous deposits, classically on the elbows, the ear, the hands, as well as over the first metatarsal phalangeal joint. And you can see urate deposits as small stones in the kidney, as shown on the right. Microscopically, the urate crystals are deposited in these amorphous deposits that elicit a prominent chronic inflammatory reaction that consists of lymphocytes, macrophages, and foreign body giant cells. Again, the tophi most often form around joints, but can occur in soft tissues and less commonly in visceral organs, particularly the kidneys. It's notable that about 20% of patients with gout eventually develop renal failure. The other crystal-induced arthritis is calcium pyrophosphate crystal deposition disease, also known as pseudogout. This may produce acute, subacute, or chronic arthritis that may mimic a variety of arthritides, including osteoarthritis or rheumatoid arthritis. Pseudogout more accurately describes acute attacks of CPPD-induced synovitis, which clinically resemble acute attacks of urate gout. However, the majority of individuals with CPPD never experience such episodes. Chondrocalcinosis is a term that refers to the radiographic calcification in hyaline or fibrocartilage. It is commonly present in patients with CPPD, but is neither absolutely specific for CPPD nor is it universal among affected patients. CPPD may be mono or polyarticular and commonly involves the joints that are listed there. CPPD occurs in several clinical forms. The most common is sporadic or idiopathic. Familial chondrocalcinosis is typically manifested as an autosomal dominant inheritance and by the occurrence of clinical disease earlier in life compared to the sporadic form. Joint trauma, including prior joint surgery, is a demonstrated risk factor for the development of subsequent CPPD as a secondary cause. Hemochromatosis is the only disease that's clearly associated with the full spectrum of CPPD joint disease, including acute arthritis, chondrocalcinosis, and chronic inflammatory and degenerative arthritis. In addition, a variety of metabolic and endocrine disorders other than hemochromatosis may be associated with CPPD, including hyperparathyroidism and diabetes. This radiograph of a knee reveals extensive chondrocalcinosis involving the menisci, which is indicated by the arrowhead, showing a linear deposition of crystals within the meniscus. Eventually, CPPD can contribute to osteoarthritic changes, and commonly both diseases are present simultaneously. The top two images of knee radiographs again demonstrate crystal deposition in menisci, and notably the image at the lower right shows extensive crystal deposition between the joints of the hand, demonstrated by these bright linear lines in the joint spaces. Microscopically, the crystals are deposited most typically in the cartilage of menisci and appear as amorphous deposits, as seen on the right, of small crystals that on polarized microscopy on the left appear as rhomboid-shaped crystals, as opposed to the needle-shaped crystals of urate that are seen in gout. The joint aspirate may show crystals along with neutrophils, although typically the degree of neutrophilia in the joint fluid is less than in acute gout. This panel compares the needle-shaped crystals seen under polarizing microscopy of gout on the left and the rhomboidal crystals of CPPD on the right. In addition, the lower panel shows cholesterol crystals, which occasionally are seen in the synovium of patients with rheumatoid arthritis. The cholesterol crystals are characteristically flat and plate-like, with a characteristic notch, so that it kind of looks like the shape of the state of Utah. The next group of arthritides that I'd like to share with you are the seronegative spondyloarthropathies. These include ankylosing spondylitis and reactive arthritis. What they have in common are involvement of the sacroiliac joints, and this may occur with or without other joint involvement. As opposed to crystal-induced arthritis, the pathology in seronegative spondyloarthropathies is in the ligamentous attachments rather than in the synovium. Eventually, this inflammatory process leads to bone proliferation, which in turn leads to bony ankylosis. These are called seronegative because of the absence of positive rheumatoid factor, which differentiates it from rheumatoid arthritis, as well as a strong association with HLA-B27. Ankylosing spondylitis occurs in young persons, typically appearing in the 2nd to 3rd decades of life. In addition to involvement of the sacroiliac joints, peripheral joint involvement occurs in about 1/3 of patients. There's a strong association with HLA-B27, but it's unknown how this HLA allele relates to the pathogenesis of disease. This is the radiograph of the pelvis of a patient with ankylosing spondylitis. The arrowhead shows joint narrowing and sclerosis of the sacroiliac joint. If you compare it with the sacroiliac joint on the left of the image, the right of the patient, it appears relatively normal by comparison. Again, about 1/3 of patients have involvement of other joints, including the hips, knees, and shoulders. This is a chronic progressive inflammatory arthritis that eventually produces spinal immobility with low back pain. This is illustrated graphically by this slide showing the clinical findings, including the characteristic posture seen in late-stage disease when the sacroiliac joint and lower lumbar vertebrae become fused together. That's the ankylosis. This slide reinforces some of the anatomy of the vertebral column that you're learning in this course, and the corresponding pathological changes that are noted in ankylosing spondylitis. The other seronegative spondyloarthropathy is reactive arthritis, which consists of a triad of arthritis, non-gonococcal urethritis or cervicitis, and conjunctivitis. This was formerly known as Reiter syndrome. This slide illustrates the classic triad, just to graphically reinforce what I've been discussing and will discuss further about reactive arthritis. Reactive arthritis also shows a strong association with HLA-B27, but the exact role it plays in the pathogenesis is unknown. The typical presentation is onset of low back pain within several weeks following an episode of urethritis or diarrhea. This is an immune-mediated arthritis that is associated with GU or GI tract infections. The typically involved joints are the ankles, knees, and feet in an asymmetrical pattern. The last arthritis I'll discuss is infectious arthritis. Most often these are bacterial, so this is known as suppurative arthritis. Note that other types of organisms can also cause infectious arthritis, including viral, mycobacterial, spirochetal, and fungal. Infectious arthritis may occur by several routes. Most commonly it occurs by hematogenous dissemination, but it may also occur through direct inoculation of the joint space from the skin or contiguous spread into the joint space from soft tissue infection or osteomyelitis. The classical presentation is the sudden development of a painful, warm, swollen joint with restricted range of motion. This slide illustrates some of the potential sources of hematogenous dissemination. The classical clinical appearance of a red, swollen, painful joint, the typical finding of numerous neutrophils in the synovium, acute synovitis, and the typical radiographic findings of rapidly developing joint destruction. There's a variety of predisposing factors to infectious arthritis, which are listed here. Infectious arthritis typically involves only one joint. The most commonly involved joints are the knee, hip, shoulder, elbow, wrist, and sternoclavicular joint. Notably, axial joints are involved more often in intravenous drug users. The typical synovial fluid findings are an opaque appearance and a white blood cell count greater than 20,000 per cubic millimeter, predominantly composed of neutrophils. The culture is usually positive, but it's not necessary for the diagnosis if other clinical features are present. These last couple slides are to aid in distinguishing the different arthritides from each other. This is a differential diagnosis of acute arthritis involving one joint, or monoarthritis. This slide outlines the major causes of inflammatory polyarthritis, or arthritis involving multiple joints. And finally, this is a nice table that outlines some of the things that can be used in synovial fluid examination to identify one of the broad categories of arthritis. Thanks